Okay, let's move to the next speaker. So next is Dr. Goldberger. He is very famous dermatologist. So welcome.
Thank you. All right, good morning, everyone. We're going to rocket through this. I have 20 minutes, right? Oh, wait a minute, only 8 minutes. I'm going to try to talk about complex hypertrophic port wine stains, birthmarks, vascular malformations, some of these challenging lesions. Vascular birthmarks, that's kind of my passion. I'm involved with the Vascular Birthmark Foundation. I believe Linda Roselle Shannon is in the audience, who's been the spearhead of that. Anyway, I'll give some examples on birthmarks and how we proceed. First of all, what are the challenges that we are facing? One of my pet issues is what does trigger this vascular overgrowth, the soft tissue overgrowth. Are there stromal factors, endothelial cell factors, angiogenic factors, this cascade that Kristen Kelly talked about? And then what's the role of anti-angiogenic agents to be adjunctive or synergistic with our laser treatment? And what do we do when plateau is reached? But today we're going to talk about treatment, the treatment approach to hypertrophic port wine stains. So what is the most effective, efficient treatment, at least in my hands, what I've developed over the last 30 years or so of doing these kinds of lesions? First of all, we identify some of these Sturge-Weber patients, for instance, that develop this overgrowth. I mean, what is triggering this overgrowth? And we can see it by age 15 is one of the earliest I've seen this massive amount of soft tissue overgrowth. Age 24, this is another child in the Sturge-Weber Foundation family group that I took care of briefly. Age 30. Age 45, you see this. I always have patients bring in their pre-morbid photos, if you will, prior to the sprouting of these lesions, and I'm stuck with that question, you know, what is triggering? Can we identify which ones will expand? Here's another example, someone I saw a few years ago, age 55. This is a chart that I borrowed from Roy, saying some 60+% of people with extensive facial port wine stains by the age of 60 will have some degree of thickening. So what is triggering it? This alphabet soup, this cascade of things that basically, when you see a diagram like this, you know how complicated it is and where do you attack this cascade of cytokines in terms of the cascade that's going to really help. We're going to be doing a study hopefully with imatinib, as you see on the right, which is a c-KIT inhibitor, in hopes of both preventing and or maintaining some of the effects of our laser treatment. So pulse dye often is not enough. So here's an example back. This was in 1992 when I did my first combination treatment with this gentleman with the hypertrophic area. And I said, well, let me try the CO2 laser. And so at the same session, we did pulse dye first, followed by CO2 to debulk these lesions. And I'm using kind of a similar technique now 30 years hence currently. And we'll go through that a little bit. And what is the role for these ablative, these adjunctive treatments to ablation? So here we have an example of a teenager with use of rapamycin. I'm currently using rapamycin or sirolimus pre-op, and with hopes of at least stabilizing some of these lesions. Some of these kids don't do well enough. They don't want laser treatment, but often we'll use it adjunctively with laser. Wonderful work by Stu Nelson. This was some years ago, where he showed, this is in a mouse ear model, he showed the use of rapamycin in some of these agents. If you look at day 6 on the upper with laser only, and then the lower, you can see how it maintained and ablated these small vessels. So hopefully some adjunctive antiogenic agent can really help our use of optimizing treatments. I did kind of a little pilot study years ago, about 10 years ago. We did little areas to see if it's safe to do concurrent use of pulse dye with CO2 and rapamycin, which I see in these quadrants. And you can see in the lower right that we're able to do adjunctive treatments at the same time. So just armed with that, I'm going to talk about my current approach to vascular lesions then. Some of these challenging lesions, as you see here, both rhinophyma, as Paul showed those beautiful examples, plus these challenging vascular malformations. So What do you do when someone like this walks into your office? Do you panic? What you need to do is really try to break it down and try to systematically say, what tools do we have? What can we use to help here? Well, we have a port wine stain, so we can certainly work on our pulsed eye and or KTP, as Dr. Kelly mentioned. The nodules, we can use a 1064 to help shrink some of those nodules. And then the lip elongation and overgrowth, we have to surgically debulk some of that and decrease the elongation of the lip. So that's with excision. So we do all these things kind of incrementally, and I just want to demonstrate, we have the port wine stain that we all have a lot of experience with. This is in infants, obviously. We try to get these cleared, ideally in the first year of life, as you see here. And if I can run this video here. Well, you all know how. So this is basically just showing I've anesthetized or just basically done some lidocaine blocks here, and we confluent area. This is, I like to see this dense purpura when we're doing a pulsed eye, and we overlap 30% to get nice coverage. And as Dr. Kelly mentioned, we can get similar results both with a 532 and a 595. It's great to have redundancy in your office. If your my 595 was down one day, I just pull out the 532 long pulse and I'm able to get a similar kind of response on my port wine stains. We bring them both to a purpuric endpoint, as you see in that second to the left image. So if you're just getting started with dealing with these and you're a little antsy about how to proceed, this is a great, simple lesion to work with, and I use a combination 532 or 595 and a 1064, so I get nice results. Typically just one treatment, but this is a great way to practice treating blebs and thickenings in your vascular malformations with venous lakes. And other examples, these are a little more complex and challenging, if you will. These are venous vascular malformations, straight 1064 we used in these cases. Here's an example. Someone came in, and I didn't know if the plastic surgeon was going to take care of this. He said, why don't you give it a try with a laser a few times, and post 4 treatments, we did 1064, 595 and 1064, followed by fractional CO2 to kind of shrink the balloon that was stretched, as you see here, and we got a very nice result. And he came in after 3 treatments and said, Doc, do you think you can do a little bit more for that puffiness under the eye? So we did another treatment and got him a notch better. So this is an example of a progression that we did with 595 and long pulse 1064 in that second diagram. Then you can see, is my mouse showing up? Probably not. I don't have a pointer. But you can see post 1 treatment and then post 4 treatments. In 30 years ago, this would take me 25 treatments to get what I can now do in 4 treatments using combinations, 595, 1064, fractional CO2. We all have these devices, or most of us have these devices, and we should be using them to optimize our treatments. Example of a bleeding lymphadovenous complex malformation. In this, we temporize using, again, a vascular laser followed by a fractional CO2 laser to knock these down and flatten them out. Here's a challenging venous vascular malformation. We used nasotracheal intubation, and I wasn't sure I was going to do much on this, but we used an electrosurgical, a cut coag device, and basically honed it down. And as you see in that second picture that was immediately post-op, I thought I'd do it in staged manner. We had the patient on prednisone and Benadryl, but we saw post-op, it did great, and healed with secondary intent, did a beautiful, beautiful result. So he was very pleased with that. So going to that and looking, what other tools do we have to debulk lesions? And I use this cut coag device, as you see here, when we do rhinophyma, and I use the same thing when we're dealing with some of these hypertrophic scars. So here's just a little quick video, if I can get this to work. Can I just roll this along? And so this is basically an example of
starting.
If I can
directly through.
Yeah, we're using a cut coag. Can I move this? I want to move this a little farther. I guess I can't. I'm trying to advance it without going through the whole thing. But I use this flat spatula to smooth the contours after we've debulked. And so what's the approach then? The first thing is to use a 595 1064. Then we use a electrosurgical device as well as a fractional CO2 to hone this down. As you see this upper lip, we didn't use any debulking. You can see how little benefit we got without the active use of an electrosurgical device. This is with fractional CO2 alone. Without the electrosurgical device, we subsequently went back and did the lip with that and debulked it. And we can see that we did some surgical correction to kind of shorten that lip elongation. So we did some surgical treatment and combination. So here's an example of how we attacked that. And the lower right, you can see we made significant progress on getting him his face back. And these people are some of the most satisfied patients and grateful patients. So this patient walked in. Similar kind of approach, again, a combination approach where we used a combination of pulse dye laser, 1064, electrosurgery, and fractional CO2. And after 4 combination treatments, we make a significant improvement. Here's someone who came in from Austin just 6 months ago. And he was sent out the next day, as you see, with this jaw bra, we called it, so he could get on the airplane. And let's see if I can have a video. Unfortunately, I don't think can I advance this video? So you see his thumbs up. We use a little topical. Use some intramucosal blocks here, plus subsequent blocks around the lesion peripherally. We use some Pronox to get him nice and comfortable. He's had a little sedation with a little Valium and a little Tramadol pre-op. And as you see, he's got the Pronox going, and then we do a series of blocks, and then we use our lasers thereafter so we can comfortably proceed. I won't bore you with the whole treatment. Another treatment approach, this was shared by Dr. Buxeda out in Spain, and he almost exclusively uses the CO2 laser. And here's a video clip that he shared with me, if I can get this to go. And you can see that he has a very high-powered, full field ablative CO2, which should roll here. Here we are. So you can see he just hones it down, just as you see, it's kind of in a defocused mode, just visually flattening these blebs. So you can do it either with a cut coag loop or with a sharp blade, if you will, that's cut and also has coag capability, so you're not, this way you can control the bleeding pretty well with the CO2. So he honed this down and was able to get a nice result just with a single treatment. Another, just proviso, just be careful with the 1064. This was about 15 years ago, and I was a little too aggressive, and 1064, you can get full thickness treatment that can create scarring, as you see here, but I was able to, as he came back 20 years later and said, could you fix it? And you can see the result, and we combined again the pulse dye with a fractional CO2 in the lower right to get him a nice, pleasing result. And again, trying a new modality. This was with the 755 long pulse, and I learned quickly that the endpoint there, you got to respect the endpoint. He was very gracious in allowing me to fix this for him, and as you see, we did a combination to smooth this out to kind of fix my own complications. So just wanted to show you these aren't without complication. It's a work in progress that Dr. Dronimus and I are working on from the Vascular Birthmark Foundation. This is one treatment, and we're still working with her to get her improved. So unanswered questions: can we identify which patients will expand early and successfully intervene early to change the natural expansion and progression? Can we identify targets for therapy and treat prior to and after laser with other adjunctive treatments? The basic take-home is use of multiple modalities. Don't be afraid to use your vascular lasers, your PDLs, your 532, 1064, in combination with the CO2, both full field ablative, fractional ablative, electrosurgical devices, excisional surgery, and adjunctive therapy. Stay tuned. We're learning about other rapamycin-like agents that Dr. Nelson told us about. Be careful of the guy in the center there, because he could be a little dangerous. So, and that's all I have today. Thank you.